Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The purpose of today's talk is to discuss with you the various movements of the mandible and the planes in which they move, and then relate this to the articulator and the analysis of the movements on the articulator. It was demonstrated to you the movements in the jaw, and we'd like to relate those to the various planes in which they move. This is a mid-sagittal suture and the coronal suture of the skull. And the mandible moves in relations to these planes. So we'd have the mid-sagittal plane, the coronal plane, which if moved forward we talk about the frontal plane, and then we would have the horizontal plane. Okay. Now on the schematic drawing that you have before you now, it shows the various planes in which the mandible will move, and it doesn't move in just one plane at a time, but it moves simultaneously in all of the planes. And we'd like to demonstrate now the border movements, Posselt's border movements in the sagittal plane, and then we'll do this with a schematic drawing, and at the same time relate the movement of the mandible to show you the envelope of motion that we have. Now, if you remember this drawing from a previous lecture, you'll see that we had a position called centric relation, which means a jaw-to-jaw relationship, centric occlusion, which the jaw moves slightly forward, which is a tooth-to-tooth relationship. And if we were to move the jaw further forward, we come out end to end, and we go out into the most forward position, or protrusive. Let's go through that once more. We have centric occlusion, and we go back to centric relation. We can move forward to centric occlusion, out to an edge-to-edge relationship, then to the protrusive or most forward relationship. Now if we go back to centric relation or the most posterior relationship, we open on a hinge axis. And we know that we can open about an inch on that hinge. After we've opened an inch, in order to go to maximum opening, which would be then B to E on your diagram, by the heads of the condyles have to slide forward. So we have a joint that both hinges and slides, and we come to maximum opening. If we were to close straight up from that, we would come to the most forward position, or protrusive. And then we can go back into centric occlusion and then centric relation. Now from centric occlusion, when we sit at rest, we go into what we call the rest position, in which there is 3 to 8 millimeters between the anterior teeth. If you remember, as we described on the patient, that we could measure vertical dimension by putting a dot on the point of the chin and just under the nose, and then measure that amount of closure. And it showed to be 2 or 3 millimeters on our patient. You can see how that works. Okay, we're going to move from the sagittal plane now to the horizontal plane, and we're going to try and superimpose this drawing. And this is demonstrated as if a stylus were attached right to the midpoint, and the movements we'd go through. So we would start now, and if we follow the drawing and the movement of the mandible, we'd go out to the lateral movements, protrusive, opposite lateral, and back in. Now let's do that again. Lateral, protrusive, opposite lateral, and back in. These are the movements in the horizontal plane. Now if you notice the CRCO on your screen, this is an exaggerated demonstration of that movement because the distance is not nearly that far. If you know the dotted portion within sight of this diamond-shaped diagram, this is probably the envelope of motion that we might use, and the very dark nearest the CR to CO is probably the chewing area that we would do. In the next diagram, then, we would show what might be the unilateral pattern of chewing, where a patient follows this pattern with the dark line being the midline, the solid line being the midline, and the C would mean center. And as a patient chews, when they first begin to chew, they have more gross movements, where they go into more movement, and then in the final stages of chewing, they would chew just around the center line, as was demonstrated in the previous diagram. So this is our pattern to show chewing, one that we demonstrated with wax to you on the patient before. Now we'd like to go back and discuss the working and balancing movements of the mandible. And I'd like to demonstrate this in such a way that you might see that when you go into working, you would move, this would be right working where we move out and the teeth would come into contact on the right side of the skull, which would be your left as you look at it now. Then we go back in. See, so you notice on the side that's a working side, you have contact between the teeth, and on the side referred to as a balancing side, there is no contact on the teeth. The other movement then is protrusive, and when you come anteriorly forward with the mandible, straight forward, why you would find the anterior teeth contact, and there's no contact in the posterior area unless there are interferences present. So we go through that once more, and move it straight anteriorly. That's an incisive action then. And this is guided by the anterior teeth. Now, one of the purposes of today's demonstration is to talk to you about transferring these movements to an articulator. And an articulator is a mechanical device which simulates the patient's jaw movements and occlusal relations. And we have various types of articulators that we would like to demonstrate to you this morning. But first, before we do that, we'd like to show you what happens if we superimpose the upper member of an articulator with the skull. And I think the first thing that you can see, the difference is that instead of the mandible moving now, why the maxilla does the moving. And what we tried to do when we relate the maxilla then to the articulator is to take the hinge axis of the patient and transfer that to the axis of the articulator. And this may be done in different ways, several different methods. The simplest method, and the method by which you will transfer the relationships of the maxilla to the hinges of the articulator, is by a face bow transfer. Now later you will be told exactly how to do this, but we'd like to tell you about the two types that we generally use: the snow face bow, which is an averaging type instrument, and you use an arbitrary hinge axis and you transfer that to the articulator. You also have a kinematic face bow, which may be a little more accurate, where you might be able to locate the true hinge axis. But the main purpose of the face bow, of course, is to relate the maxilla to the joints, or to the condyle. Okay. Now we want you to notice again that as we, if you go back to the skull, and let me just demonstrate that as we move the skull, we in essence are moving the upper member of the articulator, and the mandible stays stationary. In your mouth, if you try to do this now at the same time, you'll find that you can create the same movement, but the maxilla is stationary and your mandible does the moving. Now what we'd like to talk about is that we have to have the axis then of the articulator and the axis of the patient, or the axis of the skull, should be coincident. We'd like to demonstrate some of the various types of articulators now that are available. This is a simple hinge articulator, sometimes referred to as a barn door hinge. It has only one movement, that's up and down or open and shut. There's no way that you can compensate for a lateral movement. It's used usually for a unilateral mounting, where you just mount part of the arch. Now the next one is a slight improvement over this, but basically the same thing, but it does have some slight compensation for lateral movement, as you can see. But this is determined either by the guidance of the teeth or by the fixed pattern that the articulator has built into it. It also, you can control the closure slightly by the screw in the back, so you can regulate that. And we have just a very slight protrusive movement that can be done, and you do this, of course, then by moving the upper member of this articulator in a posterior direction. Now I have a case mounted that we'd like to show where we use a full arch on this same type of articulator. It's the same thing exactly as the last one we showed you, except then of course you have guidance from both sides, and the guidance is predominantly from the teeth, as you can see if we move it slightly. And you have slight protrusive movement, and you do have some control over the closure. However, these rely on the teeth and on your knowledge of what you would like to gain at the end of whatever you're going to do with this articulator, rather than on the articulator being a direct guide. Now we can go to another type of articulator, which in essence isn't a great deal of difference, but you notice that this one maybe simulates more the distance between the condyles. You have some slight incisive pin movement, so you can control the incisive guidance or the incisal guidance. These are all averages. They're all set on the articulator. You have some protrusive movement, which means the upper member of the articulator is going to go in a retrusive or posterior. But again, this is a set movement. You can't change it on this articulator. And the only advantage perhaps to this articulator is it more nearly is in the size relationship to the skull. Now the next articulator that we would like to go to is one that is referred to as a semi-adjustable articulator, which is the one that you will be using. It's a Hanau articulator. And there are several things that we'd like to point out about this articulator, that you can adjust the incisal guidance in such a manner by loosening the screw in the bottom, so you have some adjustment to the incisal guidance and such thing as that. You can adjust for Bennett movement. And if you watch very closely in this area, as I move the articulator, we can actually see the amount of Bennett movement. See, there's a shifting. As the ball goes into the condylar element, well, you actually can see the sideways movement that occurs. Now, if we go into left working in this area, the upper member then moves to your right. But now you try this yourself and move your mandible and go into left working, and you find that your mandible moves left. And you should do this. Try this on yourself now. You move into your left working position, and you find that your mandible goes to the left. So you can see there's a reverse direction when you go to the articulator. So the other thing that we want to talk about, and we're pointing from the back, is that you have a fixed intercondylar distance, which is an average intercondylar distance. The angle of eminentia relates to the condylar element, and this is adjustable, so we have this adjustment on it, and that relates somewhat to the anterior slope of the glenoid fossa. And then we have facility for lateral shift, we have facility for incisal guidance, and we have some facility for protrusive, and this can be set on a little adjustment which will be demonstrated to you at a later date. Okay, we'd like to discuss now the movements of Bennett movement and Bennett shift. And as you remember, why the Bennett movement came on the balancing side, and so if we start at C, and if we were to move to P, that would be straight protrusive. However, when we go into working, this condyle will follow the line C to B, and then it would form the angle G. Now if we go down to the blow-up of the diagram, we can explain it better. We start again at C. If we went straight forward, we'd go to P. Now, straight forward, we go to P. If we go into balancing movement, well, we'd probably follow the solid line C to B. We might follow it that way. However, because the Hanau is an averaging instrument, the Bennett movement would follow the line C to B on the dotted line. Because it's an averaging instrument, we'd follow that path. Now if we go to the working side, as it was demonstrated to you before, there's a cone movement in which the condyle may move. And this demonstrates that cone as you go to the working side. It can go into a lateral retrusive movement, a straight lateral movement, a lateral protrusive, and the whole combination of movements that was discussed before on the working side. Now if we can shift back to the articulator, we'll show you how some of these are set. If we want to change the angle G that we talked about, we'd set the lateral movement. And I'll set this at kind of an extreme movement, and then we'll let you see what happens. Okay. So the amount of movement then and the path of movement is affected by the setting, but since this is an averaging articulator, it'd be in a straight line rather than in the curved line. Now the condylar movement, as I mentioned before, is relative to the angle of eminentia, and this is somewhat related to the anterior slope of the glenoid fossa. Now in order for these things to work right, you have to initially have your articulator set properly. And we'd like to talk to you about the setting first before we check the articulator, and we want to adjust the incisal pin. As you can see now, we would set your lateral movements on 15 and your condylar elements on 30. And then if you notice where the incisal pin is, it has to be dead center in the incisal table. If it isn't, of course, then all your other movements would be incorrect. Now we'd like to demonstrate to you in the next slide then what happens if it's off. In this view we can see that if the incisal pin is not centered, what happens into the condylar element. It shows that it's not against the anterior part of the anterior wall. So there is an error in that. Now when we go to the next slide, which still perpetuates the error because as you set your incisive table, you can see it's not centered, so you're going to be off then in your lateral inclination. So this is an error that we would not want you to have, and we're going to show you now how to do this on the articulator, and this is also demonstrated to you in a handout. Now if your incisive table is not centered, why then we would go and you'll find two little screws in the back, and these are lock screws, and they should be loosened, and then by taking a wrench on this flat spot you should adjust that until your incisal pin is centered both in a anterior posterior direction and also laterally, so that the pin then sets in this manner. Now I want to show you why this is important, and if we can just keep that view on, we'll show that if you take off the upper cast of the articulator and you do not have your pin correct, you can see what happens. Now this relates to the thickness of your centric relation wax bite. So when you take your centric relation wax bite, you're going to have a certain thickness between the teeth, and we'd estimate it to be somewhere in the neighborhood of 3 millimeters. So you then would want to drop this pin about 3 millimeters so that when you put your bite in, and then when you remove the bite so the teeth came together, then the pin would be centered again. Okay, now if you miss it the other way and you forget to do that, you're going to have your pin will go in this direction if you forget to drop the pin, and then when you go and get ready to set your incisal table, you can see that you will not have any working room. You're locked yourself in. So it's necessary then, when you take your centric wax bites, to estimate the thickness of the wax and drop the pin that thickness, so that when you do remove the bite and the teeth come back in contact, your pin will still be centered.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.